Good afternoon. I would like to thank you for the opportunity to present our biopsy experience in over 1,000 pancreas transplants. Here we can see the evolution of our pancreas transplant program with the annual number of pancreas transplants. We can see a predominance in blue of SPK over these years, but also important is that we have a great activity in solitary pancreas transplants and SPLK, simultaneous pancreas and living donor kidney transplants that altogether represent over 40% of our pancreas transplants. So we have maintained a high volume pancreas transplants with more than 20 pancreas per year over this period. And with a growing tendency, particularly in these last 4 years. So overall, we have accumulated 1,100 pancreas transplants. Most of them are SPK, but again, with over 40% of pancreas transplants, solitary pancreas transplants activity. Here we can see the evolution and the transition of our surgical techniques. That is important because it mirrors our protocols for monitoring acute rejection. So here in the first decade of the program, there was a predominance of systemic bladder drainage. Then we switched to enteric drainage in red. Then we have a period here after 2010 with a predominance of portal duodenal drainage. In this period, with portal duodenal drainage, that we have started a graft duodenal biopsy protocol by endoscopy. And the last period here, more recent, the last 4 years, when we started performing a routine DSA and C4D monitoring. Our immunosuppression protocol is induction with thymoglobulin for all patients. Pancreatic enzymes and creatinine were periodically monitored. And regarding our DSA protocol monitoring, so from 2018 on, we started to monitor DSA routinely for all solitary pancreas transplants and SPLK at the months 3, 6, and 12 in the first year, and twice a year thereafter. For SPK patients, we just monitor DSA if they were sensitized, pre-transplant sensitized with PRA above 0, or if they presented some rejection episodes. Anyway, we have an aggressive policy for pancreas and kidney biopsies since the beginning of our program. Usually, the pancreatic biopsies are performed percutaneously. And then we analyze deeper the cases of these last 4 years for 2 reasons. These 4 years, we have a routine protocol monitoring of DSA and also C4D. And these were the years in which our program presents remains growing. So we could analyze in this period 246 technically successful pancreas transplants, of which 135 SPK and 111 solitary pancreas transplants, more 7 cases of SPLK. Here, the profile of the immunological risk of our patients, we can see here that 16 to 23% of these patients had a pre-transplant CPRA above 0, and almost 20% of our solitary pancreas transplants were retransplants. Here, we can see that most of our patients had 5 or 6 mismatches between recipient pancreas, kidney, and pancreas, or recipient and kidney. And most of our patients also had B-locus 2 mismatches in the majority of the case, and we know that it has been reported that is a risk factor for worse outcome in solitary pancreas transplants. Regarding the biopsies, so we can see here a need of biopsy higher among solitary pancreas transplants. Both groups, SPK and solitary, a good representativeness of the tissue collected, over 90% of representative samples, a higher need of higher rate of pancreas biopsy among the solitary pancreas transplants, higher rate of rejections, and also higher rates of C4D positive and de novo DSA, with a good outcome of 1 year patient and long-term patient and pancreas survival. Here, the correlation between C4D and DCA. We can see that the majority of the cases in both groups, SPK and solitary pancreas transplants, they are C4D and DSA negative. But we also can visualize that there are more cases, higher prevalence here of cases of C4D and DSA positive among solitary pancreas transplants. Regarding grade of rejection, we can note here most of the acute rejection in the SPK patients are grade 1 rejection, while in the solitary pancreas transplants, they have a predominance of grade 2 or grade 3 biopsy, and more cases of antibody-mediated rejection among solitary pancreas transplants. Regarding the rate of rejection and fibrosis, we can see that most of SPK cases showed no fibrosis in the biopsy, only acute rejections, while among solitary pancreas transplants, it was more common to have a fibrosis grade 1 or 2 associated with acute rejection. Regarding rejection treatment, most of patients in both groups were treated by thymoglobulin, but we can point out here that 1/4 of SPK patients could be treated with steroids alone. And here, a higher need of plasmapheresis and intravenous immunoglobulin among solitary pancreas transplants. Here we try to correlate the risk factor of mismatches and the impact of patient and pancreas outcome, but the single variable that showed significance was the presence of at least one rejection episode that negatively impacted the pancreas, the long-term pancreas outcome. Also, we could see that patients among solitary pancreas transplants, patients who showed de novo DSA had a higher rate of immunological loss that was statistically significant with an odds ratio of 5. The same was not detected among C4D positive patients. Regarding our duodenal graft biopsy experience, we have two main publications about the importance of duodenal graft rejections, one for the group of Norway. They presented 113 endoscopic ultrasound biopsies from the duodenal and pancreas grafts. They verified a low sensitivity of graft duodenal biopsies of only 90%, matching with rejection, with pancreatic rejections. However, they showed 65% of the paired biopsies, their results showed some concordance in the histological finds. But the authors conclude that the donor duodenum is not a useful reporter organ for rejection in the pancreas grafts. The other study comes from the group from Saudi Arabia, and they study only duodenal graft biopsy. There was no correlation with pancreatic biopsies in a smaller number of patients, but they could detect 30% of rejections among SPKs and 82% of rejects among PAK recipients, and concluded that protocol graft duodenal biopsies could detect complications and could be a useful guided therapy and carry potential for improving outcome. Our experience with duodenal graft biopsies, we have accumulated 134 duodenal graft biopsies in 52 patients. Most of them were solitary pancreas transplant patients. And we followed the standard criteria for small bowel classification, small bowel rejections. And here we can see one of the main aspects of duodenal rejection. The rejection is the cryptopoptos here starting. And in more severe rejections, we can see here a cryptic destruction and cryptic abscess. So we had 87 protocol biopsies. Most of them were normal. Some cases with duodenitis or minimal inflammation. CMV was commonly detected, but only one case of rejection was diagnosed through protocol duodenal biopsies. Among the cases for causes, 38 biopsies indicated for dysfunction of the organ. Half of them were normal. Some cases with minimal inflammation or duodenitis. Here, duodenitis seems to be more severe. CMV also was verified, and 7 cases of rejection could be detected, 18% of the case. And there were 9 other other biopsies for GI symptoms. Most of them were normal, or CMV again was verified. So in 23 cases, we could have a correlation between the duodenal graft biopsy and the pancreatic graft biopsy. So importantly here is that graft duodenal and pancreas biopsies were blindly analyzed by 2 different pathologists. So we achieved 70% of concordance in these biopsies. So here, duodenal and pancreatic biopsy, normal, rejection and rejection with different grades, sometimes of rejection between one organ and the other, and inflammations and no rejections in the pancreatic biopsy. In 30 cases, there was some discordance when the finding in the duodenal biopsy was CMV or normal or minimal inflammation duodenitis, and actually there was some degree of rejection in the pancreatic biopsy. So we could conclude from this experience with duodenal graft biopsy that a rejection of the donor duodenum was found in 6% of our biopsies. Rejection of the graft duodenum was found in only 1% of the protocol biopsies. There were 13 biopsy-proven pancreatic rejections, with 46% matching duodenal biopsies showing rejection. So it's slightly higher than the Norway study, with a sensitivity in our findings of 46% of rejection in the duodenal grafts. Among the 23 that we could have a combination of duodenal and pancreatic biopsies, there was a concordance of the results in 70% of the case. So we can conclude that protocol duodenal graft biopsies do not seem to be a reliable surrogate marker alone for pancreatic rejection. On the other hand, duodenal graft biopsies can achieve good correlation with pancreatic biopsies in cases with dysfunction and might help or might be a tool that we could use in case that we are concerned or when it's not possible to have a pancreatic biopsy. So just to conclude, most patients are C4D and DSA negative. Solitary pancreas transplant patients present higher prevalence of patients C4D positive, DSA positive. Also, solitary pancreas transplant patients are more likely to present more severe acute rejections, antibody-mediated rejections, and some degree of fibrosis. SPK and solitary pancreas transplants were predominantly treated with thymoglobulin, but the latter, solitary pancreas transplants, required more plasmapheresis and intravenous immunoglobulin. De novo DSA positive solitary pancreas transplants presented a higher rate of immunological graft loss. And finally, protocol duodenal graft biopsies do not seem to be a reliable surrogate marker alone for pancreatic rejection. However, duodenal graft biopsies can achieve a good correlation with pancreatic biopsies in cases with dysfunction. As for future perspectives, we have 2 studies to start with cell-free DNA, the first a longitudinal study and also a cross-sectional study that we will try to correlate with DSA, C4D outcome, and maybe to involve also duodenal graft biopsy. Thank you for your attention, and I'll be glad to answer some questions.